And Donna, I will openly admit, in the interest of full disclosure, that I did not pull your bio prior to my introduction to you. So if I created any of those details out of thin air, feel free to set the record straight. But in the meantime, I will turn things over to you.
Great. Thank you, Sean. And I am sharing my screen. Thank you for the introduction. And I would like to just start off by saying that I am very fortunate to have been able to participate in this project in this most remarkable year. So I appreciate the ANCOR Foundation and UCP for their leadership on this initiative. It's incredibly important that we look at public policy that is creating access and inclusion for people on an annual basis, even if this year is a little bit different. So I'd like to start off by talking a little bit about the struggles that we've had. They have been real. As you can see here, some of the struggles are new, such as program closures and service disruptions, and others are not. Staffing shortages, overtime expenses, those have long been with us. But it is the magnitude of these conditions that has been truly overwhelming this past year. You might remember a little survey we did back in April of 2020. We had about 700 agencies across all 50 states respond to questions about staffing shortages, overtime expenses, access to PPEs, lost revenue, escalating costs. What we were told was that the situation was dire. 68% of agencies responding reported having to close at least one service line, which equaled up to 32% of their average annual revenue. Additionally, 52% of the organizations responding reported overtime in excess of their typical overtime experience and projected an average impact of $930,000 per year. That's unfunded overtime expenses. These data points really highlight the fragile nature of the community-based system. From staffing shortages, financial positions teetering on the verge of collapse, and a new crack in the system, the lack of access to the infrastructure needed to keep people safe, which includes goods and supplies like PPE. Yet despite these cracks, you did it. We all did it. And you are still doing it. We're not out of the woods yet. Studies have shown that people with disabilities are only slightly more likely to contract the coronavirus. And this is in part a testament to the dedication of service organizations, support staff, and the resilience of people with disabilities. Whether someone relies on services for their daily health and safety, or simply for job support and community access, we are all learning to live and work in new ways. We've seen this resilience among people with disabilities. Some are learning to go on virtual job discovery sessions. Others are excelling at remote interviewing. We've heard stories about people with disabilities working remotely, virtually, right alongside their colleagues. We've seen individuals creating a sense of virtual community through Zoom, participating in virtual cooking classes, hobby clubs, meetups, and such. And adjusting to the unfamiliar circumstances, they're working on this to stave off isolation and loneliness, just like their neighbors. When we think about DSPs, they have been at the ready for the past 11 months. We've heard so many remarkable stories, from DSPs volunteering to quarantine with someone they support in an effort to minimize exposure to more staff, their families, their friends, working to ensure the person they support has what he or she needs to stay healthy or to weather the course of their illness. We've heard stories of agencies creating delivery services for groceries, supplies, or personal need items, and doing so to minimize the exposure of people supported. And we've seen agencies and associations hunting down PPE and making personal deliveries to program locations, individual homes, and member agencies. We've seen tremendous resilience and creativity, and we know that your initiative and your grit has saved lives and has softened the blow, has eased the blow of this epic pandemic. What we also know is that there's been assistance from state and federal programs that it has created some much needed flexibilities. These flexibilities came in a few different forms. Clearly, the resources appropriated through the CARES Act was a game changer for many. Not for all, and we're still working on that, but creating access to federal financial assistance that helped keep people employed, keep the lights on in organizations, and support services as they limp through to better days. There's also the opportunity afforded to states by CMS to waive some of their rules and regulations to help providers manage through the crisis. These flexibilities came in the form of 1135 and Appendix K waivers. The 1135 waiver eased some of the administrative requirements of state Medicaid plans, and the Appendix Ks created significant flexibility in provisions of the 1915 and 1115 waivers. And of course, there was the groundbreaking access to telehealth services that was so long overdue and was truly a game changer. And that was enabled in the first COVID relief bill to pass Congress. Of more than the 30 flexibilities made available in the emergency waivers, you can see here the 5 key waiver provisions identified by providers and advocates alike. As you will see, these provisions help to inform the foundation of our advocacy platform. Now, some are saying that CMS must put the genie back in the bottle, but we are saying no. These flexibilities were crucial during a time of crisis and have enhanced access, streamlined service provision, and served the needs of people with disabilities without harm or jeopardizing quality. Let's take a quick look at how states used the available flexibilities. Of the nearly 24, actually, I think it's closer to 30 flexibilities afforded through the emergency waivers, we identified those 5 key provisions that have been the most impactful for IDD providers. You can see here on the screen that 26 states plus DC requested and received authority to implement the 5 out of the 5 key regulatory flexibilities we identified. They included retainer payments, access to telehealth and virtual support services, electronic signatures for care plan modifications, and the ability to pay family caregivers. Conversely, this map shows the states that implemented only 3 of the 5, and it's worth noting that one state only requested 2 of the 5 flexibilities. It's also important to note that simply because a state was granted a particular flexibility does not mean that they necessarily implemented it. So what does this all tell us? How does it inform where we are going and how we can draft a blueprint for a brighter future? Well, we believe that to build a stronger system for the future, the 117th Congress should address the following areas. There should be an appropriation of additional provider relief fund dollars, and currently there's $1.9 trillion teed up in the reconciliation bill, which specifically includes $9 billion to fund an FMAP increase of 7.35%, which is dedicated specifically to HCBS services. The bill also includes elements of the HEROES Act to aid in sufficient staffing, access to PPEs, and training for telehealth and remote services. The crisis has clearly demonstrated the need for a standard occupational code for DSPs. From the fight to be recognized early on as essential workers for access to PPEs and other essential worker provisions, to the same designation being needed to access game-changing vaccines across the country. Congress should compel the Bureau of Labor Statistics through the last congressional bipartisan bill entitled Recognizing the Role of Direct Support Professionals Act, to create a SOC, a standard occupational code for DSPs, and to no longer lump together this critical workforce sector with PCAs, home health aides, and other such positions. Additionally, we see that the 117th Congress should initiate pipeline programs for DSPs. These programs would provide grants to states that support recruitment, enhance training, and retention of DSPs in an effort to reduce turnover. We ask that they pass the HCBS Infrastructure Act, which would help states comply with the settings rule, implement quality measures, expand and promote employment of people with disabilities, supercharge workforce development efforts, and more. And while Congress is busy with all this, we look to the new Biden administration for support on other fronts. Specifically, we envision the following as key areas of need from the administration. CMS should incentivize states to develop a plan that addresses elements of the workforce crisis, such as low wages and inadequate funding for training, which, as we know, adds to higher turnover rates. The administration should ensure equal access to the home and community-based services by making it a mandatory service rather than an optional one, and eliminating the institutional bias in Medicaid. The administration should work with the Department of Health and Human Services to develop strategies to combat the workforce shortages and include DSPs as a segment of the Biden-Harris 100,000 caregivers proposal. And lastly, the administration should support a critical component of financial sustainability in Medicaid disability services, which we believe is the emergence of person-centered alternative payment models that include the vision, voice, and values of all stakeholders. The administration should direct the Department of Health and Human Services to provide dedicated funding to support such pilots that result in improved flexibility, sustainability of funding, and improved quality outcomes for all. ANCOR used the information we've shared here and what we've learned through the pandemic to inform our policy agenda for the Biden administration, for the 117th Congress, and to build the case for inclusion. We hope you'll join us in this advocacy, and you can do so by visiting caseforinclusion.org. You see along at the top, you can click on Stories of Impact in the main navigation menu. There you'll find stories of how the policies discussed in the Case for Inclusion have better enabled providers to meet the needs of the people they support, and about how the pandemic is impacting IDD services. We'll be adding content here on a regular basis and invite you to submit your own stories. Once you click on the Stories of Impact page, you'll see contact information for Sean Luchtefeld, and you can send your story to him, and he'll be happy to work with you to get it published on the Case for Inclusion website. You can also take action by joining the thousands of disability issue advocates at ANCOR.org/amplifier and make your voices heard. So, are you ready to join us?
Thank you so much, Donna, for that. And before I pass a couple of questions to you that I currently have, I just want to remind everybody that if you have any questions about the any of the contents of Donna's presentation, or if you just have other questions that were triggered by your review of the report and the resources at caseforinclusion.org, please put those in the Q&A. And if we don't get to them right now, we will try our best to get to them in the next Q&A segment, which will happen after our panel discussion. So we'll start with a couple of questions that we have right now. And the first one has to do with the state regulatory flexibilities that you mentioned a moment ago. Why would states not request the ability to have certain flexibilities? And following up on that, my own kind of question is, why would they request the flexibility, but then ultimately not implement it? I think you mentioned that there were some states that requested it, but then ultimately didn't roll it out to the providers in their states. What explains all of that?
You know, that's a really good question. I mean, I think to the first question about why a state would opt to not apply for a particular flexibility is probably driven by their understanding of their local system, and if they felt that the system was structured in such a way that they didn't need a given flexibility. I have not had conversation with state administrators on that point, but it would seem to me that if they did not seek out a flexibility, it's because they thought they could manage without it. Now, to your question, Sean, about why someone would request it and then not implement it, we saw that in a couple of situations, particularly early on with regard to retainer payments. And it seemed as though the state was sort of getting their ducks in a row and getting the flexibilities that they thought they'd need, but then for one reason or another decided not to implement it. Again, with 50 states, I think they all operate just a little bit differently, and they all do it in the context of what's happening in their local landscape. And so without having that direct conversation with state administrators, it's kind of hard to know for sure.
So it certainly seems like some of these regulatory flexibilities also have very real costs associated with them to the state. For ones that maybe don't have as many costs associated, I'm thinking about maybe the flexibility to use telehealth or the flexibility to deliver virtual supports. Do you think that those are likelier to be made permanent, or are there barriers to making those permanent as well?
Well, with regard to telehealth, that has been made permanent, particularly in the Medicare program. We know that physician groups nationally are implementing that more and more regularly. It's also, I believe, permanent it's a permanent provision of Medicaid. I believe states would still need to include in their state plan or their waivers sort of the infrastructure around payment for telehealth services and virtual services for that matter. But certainly there's a potential financial impact. If in a pre-COVID world, organizations could only bill for services that were delivered face-to-face, and now, there is this other avenue. I don't think that speaks to increased costs, but it might if you think about people having a broader way of accessing services. In the past, maybe somebody would have to forego some service hours because of maybe transportation issues. Well, now if they can do it remotely, that's an additional expense.
So in a lot of ways, some of these regulatory flexibilities are kind of addressing some challenges that existed well before the pandemic, it sounds like. Mm-hmm. One other question I'll pose, and then we'll transition into the panel discussion, and then we can certainly come back to any questions that folks have for Donna after that. But one person asked, has Congress, and I'm going to add, and or the Biden administration, signaled that they're interested in advancing any of the policy proposals that you outlined when you were talking about the recommendations for federal action? Does it seem like some of these have the potential to gain traction on the horizon?
Certainly. We have a number of bills that are already in. We mentioned the Standard Occupational Code bill that was submitted in a prior congressional session. If it hasn't been yet, again, this session, we believe that it will be. We've had the HCBS infrastructure bill that has been in development for the last year or so. We're hoping that that will move forward this year. And then we also have other support that we're seeing from Congress with regard to retainer payments and vaccine prioritization and such that is being spearheaded by congressional offices from around the country. So yes, we're really hopeful that we will see the codification of some of these provisions.
Great. Well, thank you so much, Donna. I'll let you, go off camera for a few minutes, and we'll kind of bring you back when we get to the second Q&A segment, which will happen after our panel discussion. Great. So with the panel discussion,